Good afternoon, everyone, and welcome to this symposium provided by the Cytokine Signaling Forum and sponsored by Lilly. My name is Elena Nikiforu. I'm a rheumatologist from King's College Hospital in London and a senior lecturer at King's College London. And I'm delighted to be here today with our two esteemed speakers, Professor Peter Nash from Griffith University in Brisbane, Australia, and Professor Lorenzo Dagna from the RCCS San Rafael Scientific Institute in Milan. And welcome to all of you to this session. These are our disclosures. The objectives of the meeting are threefold. Firstly, to elucidate the current understanding of JAK inhibitors, their safety and how they fit within the treatment paradigm for RA. To think about ways to optimize JAK inhibitor use, including identification of target populations and treatment strategies, and to have discussions around what line of treatment JAK inhibitors would best be used in, considering also latest updates to labeling. Here is the agenda. So Professor Nash will focus on clinical considerations when initiating JAK inhibitors in RA. And we will then hear from Professor Dagna on clinical considerations in managing RA patients already on JAK inhibitors. We'll have plenty of time for discussion as well, and we would really welcome your thoughts and any questions that you may have. So please do use the EULAR app to ask your questions in writing, or come to the microphones that are found inside the room to ask your questions live. And at the end, I'll also remind you to complete your evaluation form through the EULAR app. So I thought I'd start with a few slides, just really to remind us of the immunobiology. Various cytokines and growth factors use the Janus kinase heterodimers 1, 2, and 3, and tyrosine kinase 2 for intracellular signal transduction. And JAK inhibitors block this signal transduction, specifically the JAK-STAT pathway, which is implicated in the pathogenesis of RA and other autoimmune inflammatory diseases. So we see various cytokines and growth factors here. We see IL-6, which reminds of GCA, interstitial lung disease. We see interferon alpha and beta, which reminds of connective tissue disease, myositis. We see interleukin 12 and 23, which reminds of spondyloarthritis. So huge therapeutic potential here. What we don't see are the more classic cytokines such as TNF alpha. We don't see interleukin 1. We don't see interleukin 17. So the JAK inhibitors really provide new therapeutic avenues. And in terms of the history of JAK inhibitors in RA, we do have about 10 years of history. Tofacitinib was the first drug to be approved by the FDA back in 2012. EMA approval came 5 years later. And tofacitinib offered a suitable oral alternative to injectable biological DMARDs. And following tofacitinib, further JAKs, as you can see, were developed, baricitinib, upadacitinib, and later also filgotinib, with greater selectivity, offering the potential for more efficacy and safety. And we're all familiar now with the oral surveillance trial, I believe, especially the post-marketing trial, and it was defining in terms of the next steps for JAK inhibitors. This was, of course, in view of the signals, the safety signals that were raised with the major adverse cardiovascular events, malignancy, and later also the venous thromboembolic events, which steered the regulatory authorities towards making specific recommendations for the use of these drugs, especially in certain patient populations. But in many ways, the oral surveillance study created more questions. And it did encourage us rheumatologists to really think and weigh the risks and the benefits when prescribing these agents to our patients, making us to think of those patients in particular at higher risk of cardiovascular disease, malignancy, or venous thromboembolic events. And here are questions that you can see on your screen that still remain and for which we still require robust answers in order to make the case for JAK inhibitors more robust. So what patient groups do we need to consider when deciding on treatment with JAK inhibitors? At what line of therapy can we start to consider the use of JAK inhibitors in RA? And how can we optimize the management of patients currently treated with JAK inhibitors? And with these questions in mind, I will now invite to the podium Professor Peter Nash to give us his insights when initiating JAK inhibitors in RA.
Thank you. So thank you very much for the kind opportunity from CSF and Lily just to share some thoughts about how we use JAK inhibitors. This is beautiful downtown Brisbane. We welcome you to come and visit with us, and please don't blame CSF or Lily for what I'm about to say. Just blame me, whether you agree or disagree, and we'd love to have some questions and a bit of interaction later on. That's Caravaggio over in the corner. He never signed his paintings, he'd just do a self-portrait. And this is Judas Iscariot kissing Christ, identifying him to the Roman guards. So it was only a mere 8 years ago when this was the kind of editorial, the paradigm shift. Now we've got to rethink the whole treatment algorithm because we have such enthusiasm with this new class of medication. So that's only 8 years ago. And in Australia, there's the indications and the different numbers of JAKs out there that are being used and the indications that are approved. And Australia's had one of the biggest uptakes of JAKs of any country in the world. And why? What is the advantage? Why have they been so popular? Well, they've had lovely studies which we're not going to go into because we've got a very short amount of time. They're either non-inferior or superior to the gold standard, like adalimumab plus methotrexate in rheumatoid arthritis. Of course, oral, short half-life, no immunogenicity. You can stop and start if someone has an infection, surgery, pregnancy, an issue that is of relevance. So immunogenicity, generic potential we're going to very briefly mention, and the monotherapy space is important to all of us, and I'll mention that as well. 10 years of follow-up now published for safety, and multiple new options, as we will see later on. But let's concentrate on a case. This is a young man called Henry, father of two, keen polo player, seropositive, obvious rheumatoid, barn door, erosions on imaging, can't work, can't do his polo ponies. In our country, we would start with methotrexate, of course, orally or subcut. Given the EULAR guidelines and how sick he is, we often start low-dose prednisone, but these days, because once people have prednisone in their hands, they often yo-yo, take the tablets when they're bad, stop when they're good, very difficult control, and we often try to use intramuscular instead of oral if we can. And we need a second agent for 24 weeks before our patients can get reimbursed biologics, so we usually add hydroxychloroquine in, and that gives you some protection against diabetes, cardiovascular risk, etc., etc. But as is not uncommon, if you talk to your patients who are on methotrexate, they don't always tolerate it very well. We did a study where we took 1,300 patients taking methotrexate and asked them what they thought of the drug, and about a third weren't taking it the way we thought they were. They'd stop it frequently, they'd stop it for long periods of time, and another third were convinced of how important it was, but they would stop it tomorrow if they were allowed. So there's some simple numbers. He had some benefit from therapy, as most patients do, but it wasn't fantastic. He still had some swollen joints and elevated inflammatory markers. And so at 6 months in our country, if they're not doing well, you have the option to think about biologic or targeted synthetic therapy. Now, you can pick your biro, you can pick a biologic. Many places, because the biologics are so much cheaper, you're almost forced to have to use a biologic straight away. Many European countries, Denmark, etc. And I was told today by Ernie Choi that now the biologic is cheaper than subcutaneous methotrexate in England. So cost factors drive choice, whether we like it or not, but the new updated recommendations really show you that there's the choices, a BD mud, but they haven't discounted the JAKs. They've simply said, consider the pertinent risk factors and individualise your choice. And then they list the EMA, the risk factor considerations: over 65, current or past smoker, cardiovascular risk. Risk factors for malignancy, I don't even know what that means. Does that mean colonic polyps and you're out? Does that mean Barrett's esophagus and you're out? This, as we'll see when we discuss oral surveillance, one drug in one disease, the whole class affected for every indication, really without much in the way of evidence. So who do I consider for a JAK? Again, it's no different to what you've all been doing for years. It's convenient, it's oral. Some people don't like needles. Other people have to have someone give them the needle, like a general practitioner. If you travel, the cold chain can be a major issue. Some people get injection site reactions. In many countries, they stop and start, and then you start worrying about immunogenicity with injected therapies. The rapid onset and offset does have definite advantages. This chap wanted to father another child and was worried about staying on medication long term. And again, monotherapy is something that we'll very briefly discuss, because there are 4 pillars of any therapy. You have to be convinced of efficacy. Patient preference and convenience now comes into play. Cost, access, generics are issues, but of course safety is the major issue we're all worried about now with JAK inhibitors, and I'm just going to give you my version of safety. Efficacy, everyone is convinced and have seen for the last 10 years these studies head-to-head, some of the few in all of rheumatology, methotrexate inadequate responders, oral strategy as good or equal, RA Beam and Select Compare, the first ones to show superiority over the gold standard, as was Finch. And why? It was driven by pain, patient global, physician global, not by swollen joint count, ESR or CRP, that superiority. And it just shows you the effect on pain and how patients get relief reasonably quickly and tolerate these agents particularly well. There's no need to go into the efficacy. You've seen it all before. And patients love oral. They do. If you've ever had to inject yourself frequently, you really do it, but you do not enjoy it, as I know from personal experience. So oral's preferred if possible, and I don't want to make a big play of it, but I come from the Asia Pacific, where there's 3 billion people. I've done free clinics in Cambodia and Phnom Penh. These people cannot afford more than 2 or 3 weeks of any therapy that we're all used to using. Their rheumatologists know all the data. Access is the issue. And it's time that we, with generic options like I've listed there, that come from Bangladesh or India, of all the major JAKs, cost 50 cents a tablet, 90 cents an extended release tablet. We may be able to treat vast numbers of people effectively in countries that otherwise had no access to important therapy. What happens, even the guidelines say you have to combine treatment with conventional synthetic DMARD, but in every country around the planet, including ourselves, about 1 in 3 patients cannot tolerate or have a contraindication to methotrexate, pneumonitis, hair loss, nausea, etc., brain fog. So we have an important space, and in our country we only have tocilizumab for that monotherapy space, where methotrexate is inadequate. And a lot of our patients drink too much alcohol. They say if they drink more than your rheumatologist, they've got an alcohol problem. And so the monotherapy space is important. And there is data, and good data, head-to-head against methotrexate in naive patients across the board, that you have superior efficacy with this group of drugs. Again, I'm not going through the efficacy data in detail because you've all seen it now for a decade. But this chap got told to go to the standard adalimumab first, and of course he responded nicely because most of our patients do. And he responded well, his joint count came down, his inflammatory markers came down, but he got a nuisance side effect, which they can have. And so what do the recommendations say? Well, again, pretty much an evidence-free zone, but you can switch within class, and most people might do that once if you're a secondary failure, not a primary failure, but they can also switch to other mechanisms like IL-6 inhibition, and they've opened the door for you to switch to a targeted synthetic if you think it's appropriate for that patient. And there's the B-DMARD inadequate responder trials. Again, you have excellent evidence across the JAK class of efficacy in a B-DMARD inadequate responder population. So what did we do? He switched. He was keen to stop methotrexate, stopped because of injection site reactions. So what do we then think about? And EMA guidelines, everything is telling us non-smoker, less than 65, no history of VTE. Zoster is the kind of issue that we then tackle if we haven't tackled it before. And it might surprise you to know which of your patients is at the highest risk of zoster at the youngest age. It's your lupus patients, whose risk is high from their 20s. And we don't make a huge fuss about zoster, but now we have this conversation, and fortunately we have a killed vaccine that we can recommend and use without having to stop these patients' therapy, and we're quite aggressive with vaccinating our patients, and our government has just made it freely available for any immunocompromised person over 18. So we can vaccinate our patients with Shingrix, and one of the worries that many rheumatologists have, will that aggravate their rheumatoid? Well, Michael Weinblatt has done some lovely studies to show that about a 7% flare rate, and very few patients had to even modify their therapy other than some extra prednisone for a couple of days. So we are quite confident that we can continue to use Shingrix in this patient situation. And this morning, Kevin Winthrop, and there's a poster where he talked about the use of zoster vaccination in patients on upadacitinib quite safely to use it. So screening, we always do a quantiferon, a chest X-ray. I only do HIV in the at-risk patient population. I like to keep the lymphocyte count above 500, whether it's leflunomide, azathioprine, whether it's mycophenolate, whether it's the JAKs, methotrexate, because you're less likely to have an opportunist infection if your lymphocyte count is above 500. We might check lipids after 3 months. We don't spend a lot of time checking CPK because very few people have any symptoms related to JAKs and CPK, and we do the usual kind of methotrexate monitoring, and we'll talk about skin checks. So hold on, the issue is safety. That's why we're here, that's why we're concerned about JAKs. And I'm just going to give you my thoughts very quickly about the safety aspects and oral surveillance study. You can easily make a list of the things that JAK inhibitors can or can't do that we can think about keeping an eye on. Infections, MACE, malignancy, VTE, they're the major ones. The other things are really most uncommon and more a nuisance value than anything else, and we can happily discuss them as you wish. So this is what rocked the JAK world and made us all reassess, and as I've already said, one drug in one disease, and they slapped the FDA a class black box in every indication, and that had ramifications around the world. So let's just have a look at MACE as an example, because none of this is statistically significant. This is all numerical differences. And if you look at, you have to treat 587 people for 12 months to have one extra MACE that was non-fatal, and the difference is between 47 events and 35 of 7 events. You move 5 patients either group and you've eliminated the numerical difference. And what drove it? The kinds of things you'd expect: smoking, age, diabetes, etc. Now, if you've had no history of cardiovascular disease, you do not have increased risk. The group that had the highest risk were over 65, obese, happened to live in the United States and had a history of cardiovascular disease. What about malignancy? You have to treat almost 300 people to get one extra event. 62 versus 42, no dose effect this time. Again, you only have to shift a small number of patients to eliminate the numerical difference. But what drives both malignancy and MACE? It's smoking. And we'll talk about that in a minute, because there's an imbalance in the baseline demographics by chance. And it was lung cancer that drove the difference in malignancy. There is no doubt there's a non-melanoma skin cancer signal with JAKs, and we do a yearly formal skin check, and the GP keeps an eye on the skin, because I live in the skin cancer capital of the world. So there's no doubt methotrexate does the same, TNF does the same, JAKs do this. Please don't underestimate the skin. But in my neck of the woods, melanoma is a large problem. And there were 5-to-1 melanoma in the TNF versus the TOFA, and a 3-to-1 prostate cancer. And what about lung cancer? That was the difference, 13-to-7. And if you looked at the baseline demographics, and it's a bit hard to read, but on the TNF side, there were 40 people, more people who had never smoked compared to TOFA. And remember, we only had to move 5 or 7 people. And on the TOFA side, there was 60 more people who were current smokers compared to the TNF. And we only had to shift 5 patients either side. So I'm just saying that sometimes the baseline demographics have gross impacts on things when the events are rare, numerically different, and not statistically significant. Because they've not been able to show this difference when they look in 100,000 people in the STAR study or the Corona registry. So is it a quirk of the study? Is TNFs more protective, etc., etc.? So I just ask you to roll your mind back to EULAR in Glasgow many years ago when this paper was presented. And look, placebo only had 9 lung cancers. This drug that I've hidden had 30. What should we do with the black box warning for this drug? Guess what it was? Risedronate. Now, do you believe that 10, 20 years later, risedronate causes lung cancer? There's a lot of osteoporosis patients out there that would like to know the answer to that question. So sometimes these things can be difficult. I'm running out of time, so I better hurry up. VTE, of course, there's a signal. We have to be wary about the history of VTE, and I still don't understand the mechanism of action. I don't know if this is a JAK2 inhibition effect or a class effect, but we've been involved in looking at 15,000 patient years of UPA, and this has been nicely published. Please have a look. The rates of MACE and VTE were balanced across the methotrexate and adalimumab arm. Please have a look at this paper of Peter Taylor's, where on the CSF website you can download the slides, you can look at the publication. This was many thousands of patients and many thousands of patient years of follow-up. They didn't show any signal with the other diseases, alopecia areata or atopic dermatitis. Please have a look at the Salinas paper, where there was a small difference in VTE from a number of registries around the world. Again, many thousands of patient years of follow-up, and those important papers you should have a look at. At this meeting, the filgotinib data up to 8 years has been presented, and they seem to have less of a signal of zoster or VTE. What happened to our patient? Of course, he did nicely. I wouldn't show you a patient that didn't do nicely and is quite happy. And so, whoops. And so this is what normally happens. Big hype, side effects, stop it. And now we've got to reach the plateau of productivity and use it in the most appropriate patient and think about who we should be careful with. Because if you look at clinicaltrials.gov, there are 270 trials ongoing in all those different diseases. And it's topical, and it's intranasal, and it's an aerosol, and it's all kinds of orals and injectables and all kinds of diseases. So what do? We have to learn to use them wisely and think about risk and benefit in each patient. We have to consider the cardiovascular risks, actually ask our patients to stop smoking as we're giving them very expensive medication, and do some yearly skin checks, because we don't want to throw the baby out with the bath water, and we don't want to be accused of being spin doctors. So I thank you very much for your time.
Thank you very much, Professor Nash. A very nice presentation. Please, any questions that you may have or comments, put them in the Q&A section of the app for this session, or make a note of them. We'll come back to this, questions and discussion at the end. I'd now like to invite Professor Dagnan to give us his take on the clinical considerations when managing patients already on JAK inhibitors.
Thank you very much for this nice introduction and for the CSF for inviting me. Now my task is definitely easier after the fantastic presentation of Professor Nash. And I will be focusing, however, to a different type of patient, who's actually the patient that is already on JAK inhibitor at this time. So these are my disclosures. And as it already has been pointed out, you know that EULAR recommends when the first-line conventional synthetic DMARD has failed, to add, if there are negative prognostic factor, a biological DMARD or a JAK inhibitor. And as Professor Nash reminded us before, this option should be done after taking a risk assessment for the drug. And indeed, there's a list that has already been pointed out of conditions that should be taken in significant consideration in those patients. Will we be making this decision? And as you know, also, there's the final decision of the European Commission after the CHMP and PRAC consultation. And indeed, the JAK inhibitors should be only used if no other suitable treatment alternatives are available in patients that are 65 years of age or more, if they have a history of atherosclerotic cardiovascular disease or other cardiovascular risk factor. And also this definition, as it was perfectly pointed out before, is a little bit vague. And also patient with malignancy risk factor, and again, also this definition is significantly vague. Also, we know that patients should be evaluated for risk for thromboembolism or venous thrombosis, and if the patient fit in one of this group, actually we should be considering the possibility of reducing the dose of the JAK inhibitor if this is available. Those are the recommendations of the EMA. So what should be doing if a patient is already on JAK inhibitor? And again, we should take advantage of the principle that EULAR in the last adjournment of last year suggested us, and I will be actually pointing out to about 2 points that are there. First of all, that we should be aiming at the best care for the patient, and also that our decision is not the physician decision. It's a shared decision between the patient and the physician. And also, many other factors should be taken into account, such as disease activity, safety issues, and other patient factors. So this is a generic way we proceed when we think about a specific treatment for our patient. And so, what we do, I feel that it should be doable in a patient that is already on a JAK inhibitor. Clearly, we have the duty to explain to the patient what are the content of the recommendation. This is something that we have already systematically done. And then we have to discuss, since we want to reach a shared decision with the patient, the individual potential risk and benefit ratio for maintaining the treatment, but also for changing the treatment. This is something that we have to keep clear in our mind. There's a risk if we maintain the treatment, but there's a risk if we change the treatment. And this is something I want to discuss with you within the next minutes. And also, clearly, we should be discussing about potential alternative. So clearly, we have 2 different scenarios. This patient is already on a JAK inhibitor, and the patient should be a non-adequate responder to this first or subsequent JAK inhibitors, or the patient may be an adequate responder to this JAK inhibitor. And clearly, those 2 scenarios are different. But also, we should differentiate more. So in the first scenario, if the patient has risk factor in the other 2 scenarios there, sorry, if the patient has risk factor for the JAK treatment, and so we have to keep this in consideration. But also there's another scenario, which in my clinical practice, and I think in your clinical practice also came out. The patient may not have the specific risk factor, but is fearing of the great discussion that have been around about JAK inhibitors. So is actively asking for something because he's frightened by something. And clearly is the second scenario, the most quiet scenario. The patient has no risk factor and is not fearing them. So let's start to the first of the two that I discussed. So the patient is not an adequate responder to a first JAK inhibitors. And let's take an example and advantage from this case. This case is a patient that has a long-standing story of rheumatoid arthritis, is a male, is 67, so more than the age limit that we've discussed before, is a current smoker, is got dyslipidemia, is hypertensive, and was previously treated with methotrexate, then with abatacept plus methotrexate, then with adalimumab plus methotrexate, and now is on baricitinib 4 mg. And at the last clinical evaluation, he has a moderate disease activity with a DAS28 of 3.9. So when a patient is not a responder to a first JAK inhibitor, we have two options. We can switch to a different drug, to a different biological drug, or we may be cycling to a different JAK inhibitor. And if we stick again to the recommendation that EULAR last year suggested us to follow, we know that when we fail a biological DMARD or a targeted synthetic DMARD, we could either consider a different mechanism of action or the same mechanism of action. And specifically, it is well said that if patient has failed one TNF or one interleukin-6 receptor antagonist, actually it could be cycled to another mechanism, to the same mechanism of action. This is due to the fact that there are data suggesting that, for example, here, this is the registration trial for sarilumab, and you know that patient treated with tocilizumab may have a benefit receiving further sarilumab. So even if we remain to the same mechanism of action, we may be having an added benefit for that. And also, this is the data from golimumab trial, and as you know, golimumab was effective not only in patients that were TNF naive, but also in patients that were TNF non-responders. So there's the chance of using TNFs after the other TNF. Actually, other study showed a slightly different scenario, suggesting that probably cycling TNF between other molecules may not be so effective. For example, this study that was published a couple of years ago showed that actually switching to a different mechanism of action may be more effective to TNF. So there's a kind of gray zone about there, but that's an option. And we should considering cycling JAK inhibitors. Actually, the response came from this large observational study, the JAKPOT study, and this study is made up of 16 registries put together, and the analysis of this data that includes more than 43,000 treatment courses actually was able to show that there's a substantial identity in this patient if you give a patient that is already on a JAK inhibitor another JAK inhibitor, or if you give another mechanism of action. So the efficacy is more or less the same. Actually, if we sub-analyze the study, it's quite said that if the patient has been changed, the decision to change the drug was made according to the fact that this patient experienced an adverse event, actually that may be, the patient may be at risk of experiencing the same adverse event if cycled to a JAK inhibitor. But if the switch reason was for poor efficacy, then you have the chance of getting new efficacy by cycling to a new JAK inhibitor. And indeed, if you analyze from the same study, the variation of disease activity over time, you see that there's a substantial identity in patients in the study that switched to a different mechanism of action from those that remained on JAK inhibitors. Even if, and the study in the conclusion actually point clearly out, the patients that were switcher to another JAK inhibitor were older, has longer disease duration, and received a higher number of previous BDMARD, and has a longer exposure to JAK inhibitors. Typically, those are the patients that were cycled because we have no other chance, because they've tried almost everything. So even in this population, the switching, the cycling strategy to another JAK inhibitors was effective. Clearly, in the scenario I've discussed, probably we won't be cycling to a different JAK if JAK inhibitors-associated risk factors are present. So the patient has a non-adequate response to a JAK inhibitor. If those risk factors are present, we won't be considering that. Although, as also the recommendation from EULAR point out, in some cases, no other suitable treatment alternative may be present, and probably many of the patients that have been included in the jackpot study has those characteristics. For example, we know, again from the recommendation, that there are data supporting that if the patient, as also Professor Nash pointed out before, that if a patient is in need of monotherapy, probably he or she will be getting more advantages by taking a JAK inhibitor or an interleukin-6 inhibitor. And so if we have some inherent problems with interleukin-6 inhibition, a JAK may be the solution. So in this specific case, this patient was considered at risk. He's 67, he's a current smoker, he's dyslipidemic, he's hypertensive, and he had an active disease, and he was switched to tocilizumab 162 mg weekly, plus methotrexate. So let's analyze the other potential scenario. The patient is an adequate response to a first JAK inhibitor. And let's imagine this patient. This patient is a female, is 59 years old. She has a seronegative rheumatoid arthritis with a long history of disease. She's dyslipidemic, she's hypertensive. She was treated with methotrexate, then tocilizumab plus methotrexate, then etanercept plus methotrexate. And it was now put on baricitinib 4 mg a day plus methotrexate for the past 13 months. At the last evaluation, she is in perfect remission. However, as I told you, and I think that you have experienced in your professional life this feeling, the patient expresses her profound worries and she's extremely worried by what she's read, what she has been told about the treatment, and she actively asks to change the treatment. What we know, this is a very old slide, actually, but we perfectly know that articular function is a function, for the word game, is a function of how we are able to stop inflammation. If we get late to stop inflammation, then we have more disability. Then we have more problem with the disease. And we also know, this is again as a very old slide, but it quite clearly pointed out that mortality, so survival probability, is strictly dependent on the disease activity of the patient. So we are worried by some very small, numerically small side effects, but we have to keep in our mind that also as the overarching principle point clearly out that we should be aiming at remission or low disease activity. Otherwise, this is the risk of the patient, that maybe is not exposed to the drug, but then he or she has problem connected to a poor control of the disease activity. And if we compare the mortality, clearly, again, this is not a very, very recent data, but again, if we compare the mortality due to coronary artery disease and Hodgkin disease with the mortality for rheumatoid arthritis as evaluated by disability and by the joint count, you see that actually the situation may be looking quite similar. So we have to keep the control of disease activity. And we do also know that if we go for MACE, for cardiovascular events, if we treat to target our patient, so we ensure that the patient is tightly, strictly controlled in terms of disease activity, the risk of having a cardiovascular event is definitely lower than if we do not use this strategy. And this is clearly also being pointed out by the TICORA study that indicated us that the target, the way to move is definitely to have a targeted and tight control over our patient. Another point that we should be keeping in our mind is that quite often, if we do not get a perfect control of disease activity, we rely on other drugs, such as glucocorticoids, to reduce inflammation and reduce patient symptoms. But again, we should be keeping in mind that this strategy is associated with a worse prognosis of the patient. This is an observational study that actually analyzed the effect of glucocorticoid treatment on patients with rheumatoid arthritis and diabetes or without diabetes. And as you can see in this slide, patients that have diabetes and rheumatoid arthritis, if they receive concomitant glucocorticoid, have a 3-fold increase in mortality for all cause and a 2.3-fold increase of mortality for cardiovascular problem, which is embarrassingly superior to the data from the oral surveillance study and from the other study. But if you analyze the patients that are not diabetic, those numbers goes even higher. Patients die 4 times more if they are exposed to corticosteroids and 3.29 times more if they are exposed to corticosteroids and they are diabetic. So this is something that you should be keeping in our mind. If we need to add corticosteroid, we are dramatically increasing the risk for our patient. And so, what actually we shall do? First of all, I think we have to evaluate the actual risk factor associated to JAK usage in the single patient. And this is a two-way thing we have to do. We have to keep in our mind that our patients with rheumatoid arthritis are patients that are inherently at risk for cardiovascular disorder. And so we should be treating them and correct the risk factor in this patient if we want to improve their survival and improve their status. If they have high cholesterol, we should be treating intensively hypercholesterolemia. If they do have diabetes, we should be treating diabetes. If they are hypertensive, we should be treating intensively their elevated blood pressure. And this is something that quite often we maybe forget to do, or we ask someone, we think that someone other will be taking care of. So if we take down those risks, those correctable risk factors, we have inherently, independently of the type of treatment that we are thinking for the patient, we are reducing the risk factor to those patients. But also, there's another observation that I wanted to actually discuss about this point. This is the STAR-Array study that you perfectly know. It's a study based on insurance registry. And interestingly enough, as you know, this study has actually a large cohort, and then they perform a sub-study on the duplicate cohort. So they took out a group of patients that were exactly the same patient that could have fit the inclusion criteria for the oral surveillance study. And if we take a look at that, we see that in the real-world cohort, there's definitely no signal about risk of cardiovascular mortality in those patients. But if you take a look in the randomized controlled trial, so the oral surveillance study cohort, there's a signal, which is not statistically significant, but there's a signal. And if you try to somehow, I'm sorry, but this is moved a little bit, but believe me, if you look at the distribution of this, the pool HR down there, and the finding from the oral surveillance, they are more or less superimposable. So if you analyze in a real-world cohort the cardiovascular risk of patients treated with tofacitinib and compare them with TNF inhibitors, also in the STAR-Array study, there's a superimposable result. But the interesting thing is the next finding. If you perform a multivariate analysis on those patients, you find that all of the signal is coming from the fact that from the patient that has a previous history of atherosclerotic cardiovascular disease. If you find, if you take a look at the second analysis here, so if the patient has no history of atherosclerotic cardiovascular disease, JAK inhibitors seems to protect the patient against a risk of MACE. And this is probably due to the fact that they are extremely effective, as it was pointed out, in reducing inflammation and controlling inflammation. So if there's no risk, no tracks, no history of a atherosclerotic cardiovascular disease, they may be even beneficial, protective. And if you analyze the other point in the STAR-Array, which in the duplicate cohort, you see that male versus female sex, no difference. Age 65, age less than 65, no difference. Usage of one or more DMARD, no difference. So again, probably what time will be teaching us is among those generic risk factors, some of them are significant, and probably atherosclerotic cardiovascular disease will be the significant one. Whereas there are others that, by the way, are correctable. So we can work on that. We can reduce BP. We can control diabetes. We can control hypercholesterolemia. They won't be influencing that much the outcome. So The other thing that we could be doing is to consider a reduction of the JAK inhibitor. And you know that also the EMA suggested, if possible, to use a lower dose of JAK inhibitor if this is feasible. And so this is something that could be done. And third, definitely we have to analyze the previous treatment history of the patient. In many cases, the patient has had a number of treatments. So again, the suitable alternative list is very, very narrow. So we have to consider this. But also, we should be considering the risk-benefit profile of switching. If we change the treatment, this is not a decision that is free of risk. We risk to lose the remission, and as I told you, that may be a significant determinant of mortality and morbidity. We have inherent risk associated with a specific new treatment, and also consider that many patients, as the colleague said before, need monotherapy. And again, not all the treatment could be effective if in monotherapy at the same way. And again, going back to our patient, she was extremely worried for JAK risk. She asked to change the treatment, and we agreed with her. Although the risk factors were mild, she was just mildly dyslipidemic and hypertensive, and she was switched then to sarilumab 200 mg plus methotrexate, but after 3 months, she was in moderate disease activity. So sarilumab wasn't effective to control the disease, and actually the patient came back saying, I want to go back to my previous drug. And she was switched back again to baricitinib 4 with good disease control. So to try to conclude my discussion, I think that we are somehow thinking of the recommendation versus the data that show us that a very good control will be giving better chance to the patient. But probably the problem here is not an antagonism. We need to put the two things together. This is the work that the physician since the time of Hippocrates does. Evaluate risk, evaluate benefit, and make a good decision. So definitely we should be thinking that treatment should be aimed at reaching a target of sustained remission or low disease activity in every patient. This is the overarching principle that we have to keep in our mind. We know, and also the previous discussion pointed out quite clearly, that JAK inhibitors showed efficacy, effectiveness in both CSD-MARD and BD-MARD failure. They have a quick response, and the response is maintained over years. And they're excellent, they show excellent efficacy and persistence even in monotherapy. We also know that probably different JAK inhibitors may have different specificity, and we know that clearly the inhibition, the profile of inhibition of specific cytokines are different from one drug to another, and likely, if jackpot suggested us that you can cycle to another JAK inhibitor and that will be giving efficacy that the other drug is not able to give, probably also the profile of adverse event will be different. So I quite agreed with the fact that the regulatory agency needs to be extremely cautious. But I think that time, as the case for Risendranate was pointed out before, will be clarifying these problems and this ambiguity. And again, the recommendations probably are ongoing and will be varying over time, I'm quite convinced, and I think everyone in this room is convinced about that. And we will be needing a personalized, agreed choice considering the evolving clinical knowledge and data on JAK inhibitors. And I thank you for your attention.
Thank you very much, Professor Dagner. That was excellent. And I will now invite both of our speakers on the stage, and we can start our discussion. Please feel free to use the microphones for any questions you might have, or write your questions through the app. We've got a question over there.
Hello. Thank you for the nice presentations. I have a question. In the case of a female, young female, or a female in menopause, if the patient uses estrogen or contraceptive treatment, do we need to have this in consideration for the treatment?
So when they looked at the risk factors of VTE, oral contraceptive fell out, not as a risk factor. Unusually, COX-2s did show as a VTE type risk factor. So the ones that I listed there are the ones that fell in the multivariate analysis, but it wasn't oral contraception.
Just reflecting a bit on the sort of main take-home messages from both of your talks. So I think there is no doubt that there is a very clear place for JAKs in the management of RA, and that we need to use the evidence that we have with caution and continue to take a very personalized, individualistic approach when managing our patients, depending on their individual risk profile. I struggle a little bit with the risk profile. And, you know, if we take, for example, cardiovascular risk, from your own clinical practice, say if you had a patient with non-smoker, with hypertension, I guess that wouldn't deter you. Over 65, let me make it a little bit more complex. Over 65, hypertension, no other risk factor, would you still consider a JAK?
I think I'd discuss it with the patient, of course, because it depends on their treatment journey. It depends what they've had before, what they've failed before, whether they need prednisone to survive and function and control their symptoms, just what their background history was, family history, diabetes, hypertension. So all we're trying to say is we can't ignore cardiovascular risk, we can't ignore thromboembolic risk, and then we weigh up risk and benefit and what other alternates we might have in the individual patient. It's a little more difficult, as my colleague has pointed out, those people doing very, very well for an extended period of time already on a JAK with risk factors, but have had no events. So they're a little bit difficult, as he beautifully showed.
Question
Thank you
over
very
there.
much. Very interesting talk. Dr. Tahir from Australia, Melbourne. People who are treated previously for malignancy and they are cured, are these people excluded from the JAK, going through all the journey of some other biologics?
Oh, I just missed that. What have they had before?
So people, they have treated malignancy.
Oh.
Are they excluded from JAK? They went through all this journey of using biologic, or do you have to wait for a certain time? We heard yesterday from the profs, that you have to talk to the oncologist about people with history of malignancy, and we really have to change a little bit about it.
Again, a very important question and a very common question, because very many of our patients have had a malignancy in recent times. Now, you can't get into a clinical trial if you've had any malignancy around 10 years unless it's CIN1 cervix or non-melanoma skin cancer removed. Melanoma is an exclusion. So you can't get advice on that from a clinical trial program. So it then depends on what you do yourself. I have many patients who, for example, a lady with breast cancer 2 or 3 years ago, or even develops a breast cancer on treatment. Do you continue the TNF? Do you stop the TNF? Do you continue the JAK? Do you stop the JAK? Again, you try and personalise what the journey up to there is. And this particular lady begged to go back on her TNF after we suggested stopping it. We explained whatever tiny risk there was from the rabbit registry, etc. She preferred that, take that risk. And the next patient won't take that risk. Yeah. So you have to discuss. So you can't get guidance from clinical trials. You'll get guidance from registries. And I think that is a decision based on the individual.
I perfectly agree with this. And again, what would be probably my strategy, and the strategy that I see in my clinic, is actually after a diagnosis like this, we will be, with LDNDD drug, try to go back. And maybe in some patient, the usage of other conventional synthetic that are less associated with tumor problems will be effective. But then we have to discuss back. And many, many patients will say, I feel too bad in order to get it. I prefer to go for a little risk. And also, what we know is that the analysis of registry showed that probably this perception of such a significantly increased risk for many tumors associated with biological treatment is larger than what the actual size of the problem is. So again, some patient may be well thinking of not accepting those treatments for the risk, other will be more than glad to take the risk.
And if I may come back to the point you've mentioned earlier, Professor Dagna, about the controlled risk factors. So often we will address these risk factors, we will act on them. We will act on the comorbidities. We will refer patients for control of hypertension. We use a statin. We will refer them for smoking cessation therapy. So would you feel comfortable in a patient with 3 or 4 of those risk factors controlled to put them on a JAK?
I mean, again, I don't want to be repetitive what Professor Nash has said, but again, this is an individual decision. I would be saying that probably a patient that is age more than 65 have different risk factor. Clearly enough, we have data commenting on risk factors that are not adequately controlled or that are not somehow changeable by treatment. And so we think at large. But again, probably a patient that has several risk factors and is maybe 70-something or whatever, we should be consider other options. But again, not for every patient, many options are out there. So there will be patients in which discussing with the patient, explaining the point, clearly being more strict on risk factor controlling, probably a JAK inhibitors also here would be taken into consideration. The only thing that probably would be an added point for discussion, again, saying the data from the star array study or whatever, is if the patient has a significant history of atherosclerotic cardiovascular disease. I'm not saying that in those patients, JAK inhibitor is banned, but clearly specific attention will be placed for this patient.
Just to make 2 comments, I've actually had a patient or 2 who failed every single biologic agent available with recurrent venous thromboembolism. So I've actually anticoagulated her so she could get her JAK treatment safely. And that's the kind of thing Professor Dagmar is saying. Depends on the individual's treatment journey, what choices you have and what choices you don't have. But because I'm a dinosaur, I believe that we should be commencing the statin and commencing the blood pressure treatment. We're all physicians. We all know how to measure a blood pressure and follow lipids, because when we send it back to the GP to do, or send them to a cardiologist and send them, it not only will complicate things, the GP says, well, the hotshot specialist didn't think it was important enough to start the statin. Why should I? So I think we should lead by example, but I'm a dinosaur.
Thank you. We've got a question over there.
Yes, thank you. Hello?
I think we can try this one.
Maybe because my question is behind the focus, but in all the recommendations are made for joint synovitis, pain, quality of life, and so on and so forth. But rheumatoid arthritis is a systemic disease, and with lung involvement, pericarditis, chronic pericarditis, and so on and so forth. So in some difficult to treat rheumatoid arthritis after rituximab, after biologics, what is your experience with JAK inhibitors in extra-articular rheumatoid arthritis?
There's some very nice data that JAKs are very helpful and effective in interstitial lung disease. I've not seen specific data on pericarditis in particular, but I would have no doubt that controlling inflammation systemically will also control pericardial inflammation. So I think those other extra-articular manifestations improve like all the other agents that control the inflammation. I've seen patients' nodules go down, which is always a sign that things are heading towards remission. And some of the other evidence now with JAKs, myositis, giant cell arteritis, polymyalgia rheumatica, because of the number of different cytokines that are inhibited. So I think you should be a little reassured that the systemic effects can be managed appropriately. We have over 10-year data that the TNFs using carotid intimal biopsies and ultrasounds, not biopsies, ultrasounds, can reduce mortality and cardiovascular risk. I think controlling the inflammation is paramount.
Do you have a little algorithm, perhaps, whereby depending on specific patient profiles, you would choose between the different JAKs that we have?
That's a very difficult question because we can't really separate them on efficacy. And you can't really say that much out of randomized clinical controlled trials when you'll never have a head-to-head and the numbers are reasonably small over reasonably short periods of time. And remember, only well people get into clinical trials, and you and I have to treat the bronchiectasis patient and the one who had a malignancy last year, and et cetera, et cetera. So I don't believe we have the evidence to really answer that question properly, and perhaps the registries will tell us, but even with registries, there's selection bias, and you have to be careful how you interpret registries.
Yeah, exactly. It's the same concept that came out for the jackpot study that I was citing before. So the jackpot study showed signal of efficacy in cycling JAK inhibitors, but if you sub-analyze the population that were cycling, they were older, they have a greater disease burden and whatever, so it doesn't make much comparability between the two arms. And probably if we still have some signals, it really means that you may be having different effects. Clearly, the profile of cytokine inhibition, as you pointed perfectly at the beginning of the seminar, is different. There are no specific data suggesting that a wider capacity of selection, of inhibition, of wider profile of cytokine would be better or worse in terms of both side effects and efficacy and effectiveness. So data are definitely missing, and as has been perfectly said before, there are no objective way of grading the different JAKs. Yeah.
I recommend you have a look at a paper. I saw one of the posters this morning from the German Rabbit Registry, where they asked the question, what has happened to prescribing of JAK since these rules have come in, comparing pre the rules and post the rules. And it's quite remarkable that the initiations haven't changed a lot and the age group hasn't changed either. They're still being given to older people because they've failed so many other things. And it's an individual risk-benefit analysis. But it's a very interesting poster. I recommend you have a look.
The convenience aspect is a very important one, especially for young people working, traveling. Is that something that you face a lot in your clinics, that you see a lot, people coming in wanting to start JAK inhibitors earlier than any other biological or any other targeted synthetic treatment? Do you see that there is a population of people, that certain subgroup that will really ask you for these drugs?
I mean, that is definitely a request that come out, but I personally, at least in my clinic, is not numerically so relevant. I think that the major driver for selecting as an early line of treatment is the need for monotherapy for a number of reasons. And clearly, I mean, they are more useful. At least in my personal experience, there's also a kind of strange story in the perception, at least of my Italian patient. Taking a pill is less problematic than taking an injectable drug. So they will be calling us immediately if they have some minor signs of cold, if they are injecting something, whereas if they are taking a pill, they will be, they have a good pneumonia, there is no need to signal this. So there are both sides of the same sword, of the same coin, that could be a benefit or not. I think that probably this is a driver, specifically asked by some patient. I would say that probably the major driver that I see for an earlier prescription of this drug is more the poor tolerance to methotrexate or conventional synthetic DMARDs.
Plus, if you're sitting in your clinic and you're half an hour behind and the patient is no risk factors and your choice is between an injectable where I have to teach them how to take the injection, how to travel with the injection and be careful of this and do that, or could you take this tablet once a day? So there are a lot of practical reasons as on the doctor side as well as on the patient side.
I must say, it's tempting, isn't it, especially for the younger lot. I think, Professor Dagner, you mentioned a little bit the dose issue, reducing the dose, and you reflected on some of the data. how frequently do you find yourselves, perhaps in the high-risk groups, wanting to start someone on a lower dose of a JAK inhibitor? I know that data are not really there.
I would say that in general, but also more specifically after the recommendation came out, that was a strategy that was already taken. The study on lower dose of baricitinib or filgotinib have shown good efficacy. Again, the dose thing is a little bit difficult to compare between the different drugs because there's no perfect equivalence between the different dosage, but definitely this is an option. So what I would be probably thinking of in a patient that has risk factor or have some problems that will make me thinking about the potential utility of a lower dose, to start the patient on a lower dose and look how the things are going, and then maybe going for the more elevated dose if needed. But in many patients, in many cases, also many data suggest that the lower dose will be able to control effectively the disease.
Thank you. Are there any other questions? Well, perhaps in the last couple of minutes, I can ask you one final question related to the theme of this whole symposium. So do you think we have a strong case for JAK inhibitors?
I think we'll see a huge number of new JAKs, combination JAK1, TYK2. You're going to see a huge number of indications for JAKs in other disease areas like polymyalgia rheumatica, giant cell arteritis, dermatomyositis, and interstitial lung disease. All these things need to be confirmed with appropriate studies, of course. But I think we shouldn't abandon this class. We should just learn to use them wisely.
Yeah, I perfectly agree with that. I think that, I mean, as also Professor Nash pointed out, it's quite common for a drug that at the very beginning we start looking at the drug. After a while we think that this drug is fabulous, and after that some signal came out, and then we treat everyone with this drug in this phase, and then the things goes down because we have some safety signal or some problem. And then after that probably we reach the ideal equanimity between the two feelings, and with that specific feelings we also point out some problem that we haven't thought about. I think that all this JAK story will be helping us at least to be a little bit internists and not only rheumatologists, and thinking that we have to take care not only of the arthritis of our patient, but to make sure that all the risk factors, all the problems that may be negatively affecting the prognosis of our patient are adequately addressed. And this is definitely probably the best way also for minimizing the side effect of the potential complication of whatever treatment we offer to those patients.
And we're all going to have a role where we have to advise the gastroenterologist who's now going to start using JAKs and have no experience in inflammatory bowel disease. The dermatologist is going to start using it in atopic dermatitis, alopecia areata. So they're going to come to you and say, please tell us what 10 years of using a JAK has taught you that we should be aware of in our specialty.
And on that note and your excellent remarks and insights, thank you both for your talks and for sharing all your insights with us. So this brings me to the close. Just put this on. So thank you very much to all of you also for your questions, your contribution, your participation. Of course, a big thank you to our sponsor, Lilly, for making this symposium possible. Please do take a moment to fill in your short evaluation form using the EULAR app to let us know what you would like to see next, maybe, what we could do better, what you'd like to see on the agenda next. Really appreciate your feedback. And let me just remind you a little bit of the Cytokine Signaling Forum platform. It's an educational website developed under the auspices of the University of Glasgow. Plenty of educational material there. Some of you, I'm sure, are already receiving relevant emails. Please go online and take a look. And thank you for being here. Enjoy the rest of your evening.